The nurse plays a really important role with patients and talking about treatment options. Anytime the patient hears the word cancer, they shut down a little bit, right? They may not hear everything that oncologist or urologist or whoever is talking to them about their treatment options is saying. The oncology nurse is a great person to sit down with the patient and go over the information with the patient at a level maybe they can understand a little bit more, to go over all the treatment options presented by the physician. And again, making sure that we understand their goals of care.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking again with Clara Beaver, Manager of Clinical Education and Clinical Nurse Specialist at Karmanos Cancer Institute in Detroit, Michigan, about prostate cancer treatment considerations. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation we've linked in the episode notes. Thanks again for joining us today, Clara, and welcome back.
Thanks. Great to be back.
So previously we talked about prostate cancer screening in our last episode. So let's pick up where we left off there. After initial screening identifies something suspicious, what are some of the next steps in the process for prostate cancer treatment?
So usually the patient is with a urologist at that point. And I think it's important to note that urologists are usually the ones that are doing the diagnosis of prostate cancer and really start that staging of prostate cancer. And the medical oncologists usually are not consulted until the patient is at a greater stage of prostate cancer. And I just find that is important to state because a lot of our patients start with urologists, and by the time they've come to us, they're a lot further stage. But once a prostate cancer has been suspected, the patient needs to be staged for the extent of disease prior to that physician making any treatment recommendations. The staging really includes doing a core biopsy of the prostate gland. And during this core biopsy, they take multiple different cores at different areas throughout the prostate to really look to see what the cancer looks like. They also order some imaging and additional blood work to really determine if the cancer is spread outside that prostate gland.
Often part of what we get back from some of those initial sort of workup tests is we see on the report something that's called a Gleason score. We see that in the documentation from the oncologist. So can you give our listeners a brief overview of what is a Gleason score? What are the different grades of those scores? And what does it mean?
Yeah, so the Gleason score is really from that core biopsy that we've done of the prostate. The Gleason system has been around for many years, and it really assigns a grade to the cancer or the prostate using a score of 1 to 5. And it's really based on how much that core biopsy or cancer looks like the normal prostate tissue. So grade 1 is assigned if it's normal looking. Grade 2 to 3 have features of normal to abnormal. And grade 5 is assigned if it looks very abnormal and less like prostate tissue. Almost all the prostate cancers are given a grade 3 or higher, and grades 1 and 2 are not often used because usually you're not doing a prostate biopsy if the patient has a normal prostate. But since prostate cancers have many areas, and that's what that core biopsy is looking at, there's usually different grades throughout the prostate gland. And so the grade is assigned to the 2 areas that make up the most cancer. And then these grades are added together to give what's called the Gleason score, which is what we're used to seeing on those reports. So for example, if I'm looking at 2 core biopsies and the first one has a 3 grade and the second one has a 4 grade, the patient has a Gleason score of 7. And so that's really what we're looking at. And then based on that number, the prostate cancer is then assigned to one of 3 groups based on that Gleason score. So if a patient has a Gleason score of 6 or less, it's really considered low risk or well differentiated. And these prostate cancers tend to grow a lot slower and are unlikely to spread. So you want a Gleason score of 6 or less if you're looking at it. A Gleason score 7 will be called intermediate grade or moderately differentiated. So again, those are those patients that fall into that, what are we going to do with them? And then the Gleason score of 8 to 10 is called high grade or poorly differentiated. And I think we're going to talk a little bit more about these different grades when we talk about treatment options, but this is what the Gleason score means. And so if you have a patient and they have a Gleason score of 7 or those moderate ones, those are the ones that we spend a little bit more time with looking at what their treatment options are.
Thank you so much for that wonderful review. So let's talk a little bit more about risk groups. Are there different risk groups for prostate cancer, and how might the treatment options differ for each of those different groups?
Once staging's been completed in prostate cancer, they're put into risk groups. And these risk groups really help us determine the treatment options for the patients. So the first group is the very low risk group. This is where the prostate cancer is small. It's often not felt on exam. It's only found in a small area of the prostate, not outside the prostate. Their Gleason score is 6 or less. Their PSA is 10 or less. It's usually a very slow growing cancer and rarely causes any symptoms or health issues. So with this very low risk group, there's not a lot that we're going to do with those patients. Then the low risk group, the prostate cancer has not grown outside the prostate. They have a Gleason score of 6 or less. Their PSA is 10 or less. And the way it's differentiated from very low risk is that the tumor itself is a little more larger, usually T1 or T2A, but it rarely causes symptoms or health issues. You might be able to feel this a little bit on exam. The intermediate risk group are those patients that have prostate cancers that can be felt on exam or seen on imaging and testing. The cancers can be found in more than half of one side or in both sides of the prostate. And they have a Gleason, they can have a Gleason score of 7 and or a prostate level between 10 to 20. And then the high risk group, the prostate will have one of all the features of the high risk group. And then also it has grown outside the prostate, a Gleason score of 8 to 10, and the initial PSA is more than 20. And then the last group is the very high risk group. These are patients who have the prostate cancer growing or spreading to nearby lymph nodes or other body parts. At least one of the following traits is found. The tumor is spread into the seminal vesicle or into other structures next to the prostate. The most common areas of the cancer in the biopsy have a Gleason 5 pattern, or more than 4 biopsy cores are a Gleason score 8 or 10. The cancer has 2 or 3 features found in the high risk group as well. So again, in these patients, the cancer is pretty far advanced, and that's why they're in the very high risk group.
Let's talk a little bit about some of maybe the more common treatment options that we see. Are there specific treatments that are more likely for certain risk groups?
The very low risk group and the low risk group, the most common is active surveillance. Again, most of these cancers are very slow growing. Again, the patients are usually at a little bit higher of an age, 60 to 65 is the average that we're seeing this. But the patients can be offered other options such as radiation therapy or surgery if they're not happy with that active surveillance. Again, that word cancer, right? People are like, how do I get rid of it? So active surveillance is not usually something people want to hear, but sometimes it is. So that is the most common, and that's usually what is offered to those patients. Now, the intermediate risk group has favorable and unfavorable when you look at it. So if they're a favorable, so their Gleason score is usually a little bit lower, things are not as advanced. These patients are offered active surveillance and then either radical prostatectomy with possible removal of lymph nodes, radiation, external beam, or brachytherapy are the ones that are normally ordered for these patients. If a patient has unfavorable intermediate risk, they are offered radical prostatectomy with removal of lymph nodes, or they could be offered external radiation therapy plus hormone therapy. External radiation with brachytherapy could also be offered. All 3 of these are offered to patients, although I would say most frequently we see that our patients are taken in for radical prostatectomy. And for the higher, very high risk, the patients are offered radiation therapy with hormone therapy, typically for 1 to 3 years. And then radical prostatectomy with removal of lymph nodes could also be offered for those patients.
Thank you so much for that, Clara. That was just a great overview of some of those different treatment options based on the risk group. Let's talk just briefly about biomarker testing. How can biomarker testing help oncology nurses determine or help educate patients about what the best treatment option might be for an individual patient based on those biomarker testing results?
Biomarker testing has been amazing when it comes to helping our patients determine the best treatment options for them. So, biomarkers really help determine those best treatments by identifying specific gene or molecular changes in the patient's tumor or blood. And that information really helps us determine what is the most effective treatment for the patient, for their cancer. How can we get rid of it? How can we make sure that we treat it? Doesn't necessarily mean that the patient's going to have less side effects, but really that we're attacking that cancer instead of just going in blind and not knowing what is going to work the best. It also helps with risk stratification, the cancer aggressiveness, and how the patient may respond to treatment. When we look at those biomarkers, it really helps us get a better picture of what that tumor is doing, what it's thinking, where it's going to go. It gives us a little bit better picture of what's happening inside the body.
Now let's move on to radiation therapy. Can you discuss the role of radiation therapy and how we use it in prostate cancer? And specifically, what kinds of radiation therapy treatment are used? And do they look different depending on that risk level that we've already discussed?
Radiation can play a role at any risk group, really depending on the patient's preference. Some patients prefer radiation to surgery, or it can be used after surgery when the surgeon finds some concerning features with the prostate. Sometimes the base, there may be a little bit that they're worried may still be there. So they may offer radiation after that. So really can be offered at any of the stages. And we talked about that a little bit earlier, but sometimes it's the patient's preference because surgery can have side effects that the patient may not want to deal with. So the types of radiation that we use are external beam, brachytherapy, which is an internal therapy, and radiopharmaceuticals is coming more for advanced cancer, but we are seeing that being used now in prostate as well. So for external beam radiation, it's really focusing on the tumor and any metastasis that we may have at the tumor, but it can be used at any risk and for recurrence if radiation has not been done previously. If a patient's already been radiated to the pelvic area or to the prostate, radiation really usually is not given again because we just don't want to damage the patient any further than they already have had. Brachytherapy is when we put radioactive pellets directly into the prostate. For early stage prostate cancer, this can be given alone. And for patients who have a higher risk of the cancer growing outside the prostate, it can be given in combination with external beam radiation. It's important to note with brachytherapy, it cannot be used on patients who've had a TURP, resection of the prostate, or any urinary problems. And if the patient has a large prostate, they may have to be on some hormone therapy prior to brachytherapy just to shrink that prostate down a little bit to get the best effect. And then radiopharmaceuticals are that I want to say newer and upcoming, but it seems like they've been around for quite a few years now. They treat the prostate-specific membrane antigen, or the PSMA. This is used only in patients that have prostate cancer that have spread outside of the prostate and have already used hormone therapy. Chemotherapy and the cancer cells have to have a PSMA protein, which we have a really cool PSMA PET scan that really shows us where those sites are that have the PSMA protein. It's given IV. It's given every 6 weeks, up to 6 doses. It's usually given in the radiation therapy department because those patients are radioactive while they're receiving therapy. And so we do need to make sure that we are keeping a close eye on them, watching where they're going. And then there's very strict instructions for those patients once they go home with exposure to other people in the home. But again, radiation therapy, as you can tell, plays a large role in treatment of prostate cancer.
Absolutely. Thank you for that wonderful overview and certainly highlighting the exciting, relatively new world of radiopharmaceuticals and how that has really added sort of a different treatment modality for not only patients to receive, but for nurses to be able to administer and understand how to counsel and coach our patients through that experience. Shifting gears a little bit into another modality of surgery, what kinds of surgeries might a patient need as part of their treatment for prostate cancer, specifically as it progresses? And when do we determine when surgery is the right treatment?
So surgery is really the common choice given to patients to cure prostate cancer. The thought is that if it's maintained within the prostate gland and not spread, if we remove that prostate gland, we should remove the cancer. I feel like that is what is offered to patients pretty early on when they are in the intermediate to high risk. the first thing that they'll look at is doing surgery. The surgery that's done is a prostatectomy where they take out the entire prostate. Most of the time, it's a radical prostatectomy. The surgeon removes the entire prostate, some tissue around it, and then the semivesicles as well. Sometimes lymph nodes are removed. Again, it depends on what the scanning has showed, if there's anything suspicious when they're in there doing them. It is usually done robotically so that the patient does not have a huge scar from the surgery. Sometimes there are issues, but usually it's done robotically. The side effects of surgery are usually what deter the patient from wanting surgery. The first one is urinary incontinence. A lot of times a patient has a lot of urinary incontinence after they have surgery. The other one is erectile dysfunction. A lot of patients, especially if they're a younger patient, they may not want to have erectile dysfunction, or if having an erection is important to the patient, they may not want to have surgery to damage that. Now, in this day and age, the physicians have gotten a lot better at doing nerve-sparing surgeries. And so they really do try to do that so that the patient does not have any issues with erectile dysfunction after surgery. But if the extent of the cancer where it's growing around those nerves or there's other things going on, they may not be able to save those nerves. That is one of the side effects that a lot of patients will deter the patients from having surgery because they don't want to deal with erectile dysfunction.
And I think that's such an important consideration and really highlights the importance of understanding what a patient's goals and values are and incorporating that as part of that shared decision-making, recognizing that it might be a very successful potential treatment option to use surgery, but it comes with those risks, and those risks that impact to a patient's quality of life can be very significant. And so it just, I think for me, really highlights the importance of having those very clear, forthright discussions so that a patient can understand what they're potentially agreeing to and making the decision that is right for them based on how they value some of those concerns and those risks that you noted. So we've talked a little bit about radiation. We've moved on to surgery, and now let's kind of round it out with some more systemic therapies. Talking about androgen deprivation therapy. Talk a little bit about what that therapy is, including LHRH analogs, and what types of risks, side effects are associated with this type of hormonal treatment.
Androgen deprivation therapy or hormone therapy is really given to help lower those androgen levels or stop them. And really the thought is that if we can stop them, that prevents the cancer cell from growing. Again, much like breast cancer, prostate cancer is a hormone growing cancer. The thought is if we can stop that, then we can slow the growth or stop the growth of the cancer cells. So luteinizing hormone releasing hormone or LHRH antagonists or LHRH analogs lower the amount of testosterone made by the testicles. So again, we're trying to stop those hormones from growing to prevent the cancer. There are also LHRH antagonists, which are used more in advanced prostate cancer patients because they work a little bit differently by lowering the testosterone more quickly than the other ones. When we lower the testosterone very quickly, there can be a lot more side effects. But if we lower it a little bit less, we can maybe help prevent some of those side effects or do prevention so that the patient doesn't have as many side effects. The side effects are important. When I was writing this up or looking at it, I was thinking, I'm like, okay, this is basically what women go through when they go through menopause. We're decreasing the estrogen. We're now decreasing the testosterone. So the patients can have reduced or absent sexual desire. They can have gynecomastia, hot flashes, osteopenia, anemia, decreased mental sharpness, loss of muscle mass, weight gain, fatigue. It all sounds like the same things we go through with menopause, right? They can also have shrinkage of the testicles and penis, and then increased cholesterol levels and depression or mood swings are often common side effects related to this therapy. Now, there is some research that really suggests that there is a high risk for these patients of having high blood pressure, diabetes, strokes, heart attacks, and even death from heart disease when they're using these ADTs, because again, we're lowering that testosterone, which is not regulating any longer in our body. So we do need to watch our patients for those things while they're on these medications.
So important. And it kind of, again, echoes my previous comments of that, these, when we think of all the types of treatments that we know we administer for anti-cancer therapy, hormone therapies sort of were like, that's not so bad compared to some of the other, very critical side effects and symptoms that we see with other treatment types. But again, it can be extremely impactful to their quality of life. Is it fatal? Maybe not, but certainly can be disruptive, especially if those patients don't understand what to expect or are given that information ahead of time. And so it just reinforces the importance of not minimizing these treatments, even though compared to other treatments, maybe they are slightly less toxic or causing some of those really severe side effects. They are still impactful. They are meaningful to patients. And so giving them that awareness of what to expect and some of these management strategies to offset some of those hormonally driven side effects, certainly very important to keep as part of the conversation. Talking a little bit more about androgen deprivation therapy, is this something that's needed, always needed after an orchiectomy, or does that vary from patient to patient depending on their specific circumstances?
It really varies patient to patient. The whole goal of an orchiectomy is to act as a hormone therapy. By removing the testicles, you would think if I remove the testicles, which produce most of the androgens in the body, I'm automatically doing that. So again, it's not necessarily needed because if I'm removing the testicles, hopefully I'm removing that piece as well. But it could be added if we see that the levels, we do testosterone levels on our patients. So if those continue to rise even after the orchiectomy, or if an ADT is started after the orchiectomy as a first line hormone therapy, it's really called combined androgen blockade. So again, if the tumor is really growing significantly and the physician really thinks that they need to make sure that they're blocking the androgen from anywhere that it's coming because it is produced in other areas of the body, they may do a combined therapy where they do the orchiectomy and the ADT.
Let's talk a little bit about advanced disease, progressive disease. If a patient has prostate cancer, whether it's at presentation or eventually it progresses and metastasizes or potentially even recurs, what does the treatment landscape, treatment options look like for patients at that stage of disease?
So it really depends on what we've done first line for the patient, if this is a recurrence or metastasis. If they've not had surgery or radiation first line, then they will try those or add or change the type of ADT therapy that they're using for the patient. But really, when a patient metastasizes or recurs, we do have immunotherapies that are used, targeted drug therapies, and chemotherapy is also used for these patients that have metastasis and recurrence. I think, too, it's important to note that clinical trials for metastasis and recurrence is really an option for patients. My father, as we discussed in the first episode, has prostate cancer, had a prostatectomy, and then went on a clinical trial when he recurred with radiation and an oral agent. So again, those clinical trials are really looking to make sure that we have additional treatment options for our patients. So if I have a patient that recurs or have metastasis, clinical trials is a great way to look to see what else is out there for those patients.
Now, we know that a high percentage of prostate cancers are adenocarcinomas, but could you briefly touch on what are or if there are rarer types and if those have different treatment options or are approached differently for patients?
Yeah, so there's a few other types. There's transitional cell carcinoma, small cell carcinoma, a sarcoma, squamous cell carcinoma, and neuroendocrine tumors are ones that we also see when we're looking at prostate patients. So the transitional cell carcinomas treatment is a prostatectomy, radiation, and active surveillance. There are some newer therapies looking at the transitional cell carcinoma of a laser ablation or using cryotherapy or a TULSA Pro, which is a specialized software-guided transurethral MRI-guided ultrasound system that uses heat to destroy tissue. So again, there's newer things out there that we're looking at for these patients. The small cell therapy includes chemotherapy, cisplatin-based, radiation therapy, hormone therapy, surgery, and targeted therapies are also out there for that. Sarcomas, again, surgery, radiation therapy, and chemotherapy. With squamous cell carcinoma, really looking at multimodal therapy. So, surgery plus or minus radiation or plus and minus chemotherapy is really used a lot for these patients. And then neuroendocrine tumors, we're looking at chemotherapy, hormone therapy, targeted therapies. For advanced neuroendocrine therapies, there's immunotherapies, antibody drug conjugates, And newer on the market are the DLL3 targeted therapies for the neuroendocrine tumors. So again, all of these, there are some things that we can do for them. And like you said, they're a little bit more rare. So a lot of urologists may not know what to do with these. And so that's where med-oncs, maybe some of the bigger centers come into play because they may not see these as commonly.
So, Clara, how do you globally see oncology nurses and our role in assisting patients with prostate cancer? How do we help them make informed decisions about all of this information we've talked about today and ultimately helping them to make a treatment decision?
I think the nurse plays a really important role with patients and talking about treatment options. Anytime the patient hears the word cancer, they shut down a little bit, right? Like they start thinking, am I going to die? What's going to happen next? They may not hear everything that oncologist or urologist or whoever is talking to them about their treatment options is saying. So I would say the oncology nurse is a great person to sit down with the patient and go over the information with the patient at a level maybe they can understand a little bit more than what the oncologist said to them, to go over all the treatment options presented by the physician, talk to them about what the side effects of that are. And again, making sure that we understand their goals of care. So again, remember, a lot of these therapies can cause erectile dysfunction or urinary incontinence. And how does that fall into that patient's lifestyle and their goals of care? And making sure that we're there listening and answering the questions for the patients and making sure the patients have a way to get a hold of us after, because once they go home is usually when all those questions start to come up, when everybody else starts asking them, what's going to happen next? What did they say? And you don't remember all that. So making sure that there's a way that they can follow up with you.
Absolutely. Very well said. Being that constant sort of anchor point for our patients. So as their questions arise and change over time, that we can be there to help support them. And ultimately, as you said, advocate for their values, what's important to them, and being an extension of their voice when some of those discussions are being had. So excellent points, Clara. Thank you again for joining us today on this second episode of this series on prostate cancer. As we get to the end of our episode, we like to always run through a series of quick questions just to help summarize some of the larger points we've discussed. So to start that off, how do you think healthcare professionals should evaluate their own hidden or implicit bias they might have about prostate cancer treatment?
What we all need to remember is that no patient is the same. No patient wants to be treated the same. They may not have the same goals for treatment as the physicians or the nurses want for the patient. We talked about surgery as the most common treatment modality that's presented to patients, but it's not necessarily the option that they want. It's really important for healthcare professionals to understand their biases before talking to the patients and the family. It's also important to remember that not all patients are in heterosexual relationships. So we need to explain recovery after treatment to meet the needs of our patients and their sexual relationships, which is sometimes hard for us. But remembering that, especially gay men, they may not have the same recovery period as a heterosexual male when it comes to sexual relationships. So making sure that we have those frank conversations with our patients and really check our biases prior to going in and talking with them.
What do you think are some common misconceptions about prostate cancer treatment?
I think the most common thing is that surgery is the only way to cure prostate cancer. And I think that is a huge misconception. There is research that shows that with low-grade and early intervention, radiation can be just as effective as surgery for these patients. And we may not cause as many of the issues that you can with surgery. And again, like I said, we just need to understand our patients' goals prior to offering treatment options so that we make sure that we're talking with our patients at the level that they are at.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think the role of clinical trials in patients who have cancer spread or recurrence, I think is not talked about a lot. And we do need to really make sure that we do look at that. Clinical trials really help shape the future of treatment. The other thing I think that we don't think about or talk a lot about is the role of education for recovery for patients that do not have heterosexual sex or are not straight. We don't often have educational materials for gay men of how their recovery may be different when it comes to sexual intercourse. And maybe we leave those patients out a little bit when we start talking about things. I think that's important for us to think about as well.
What additional training or education do oncology nurses need to stay current on this topic?
Like we discussed in the last one, just staying up to date with the current research and treatments that are available. We talked about some up and coming things that are newer in this realm. And every day I feel like there's something new coming out, especially with the age of precision medicine, where there's more and more targeted therapies coming available for patients. So really, it's important for the nurses to stay up to date on the current treatment options. As always, ONS is one of the great places to go to because they have a lot of resources to help us understand what's happening.
And what are some additional resources for patients or other healthcare providers, professionals that want to learn more?
The American Cancer Society has some really great patient resources that really break down all the different treatment options and talk to the patients about it. NCCN, of course, is always a great place to go to know what the treatments are. And then obviously ONS, we already said that in the last question, but ONS is always a great place for nurses to learn more and to be able to educate patients appropriately.
Well, Clara, as I said, thank you again for joining us today on the second installment of this series on prostate cancer. It's been great to talk to you and dive a little deeper into some of the treatment considerations for prostate cancer. Do you have any final comments to share with our listeners?
I just want to say that there's many options for our patients with prostate cancer, and we just need to make sure that we understand the patient's goals for after treatment to help them make those informed decisions.
Wonderful. Well, thank you again.
Thank you.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.